Hello, everyone. Welcome and thank you for joining us. Today's webinar is the Inconvenient Tooth, exploring challenges and best practices in the management of daily mouth care for older adults in long-term care. It will be presented by Dr. Mary McNally from the faculties of Dentistry and Medicine at Dalhousie University. There is a PDF file of the handout for this webinar, which has the slides. It's in the handouts box on the right-hand side of your screen. You might have to click on the arrow beside where it says handouts to get the box to expand so you can see the PDF file. I'm Kate Duchek, a project officer with the Schlegel-UW Research Institute for Aging, or RAA, in Waterloo, Ontario, and I'm your moderator for this webinar. This webinar is brought to you through the Centre for Learning, Research and Innovation in Long-Term Care program at the RAA. The RAA is a charitable, nonprofit foundation that links research, training, and practice to enhance care and quality of life for older adults. The RAA supports practice-relevant research and mobilizes evidence so it can inform programs, be integrated into education and training, and influence practice and policy. As a program of the RAA, the Centre for Learning, Research and Innovation in Long-Term Care, or CLRI, aims to enhance the quality of life and care in Ontario long-term care homes. We are able to do this thanks to funding from the Government of Ontario. And here's a little bit about me. I started studying gerontology after being part of my grandma Jean's experiences with living in a couple of long-term care homes in the early 2000s to ensure that long-term care communities are enjoyable places to live, work, and visit. So I'm very happy to support the RAA and CLRI and to be connecting with you all this morning. We are thrilled to have Mary leading this webinar today, and I will turn it over to her now.
Good morning, everyone. Greetings from beautiful Nova Scotia, where I think we're having a sunny day as you are this morning. I'm just showing a little picture of myself here in the beautiful Annapolis Valley of Nova Scotia, where I'm picking grapes. And I thought this picture was not only a way to kind of put a face to the talk this morning, but also just to help me situate myself within this topic. When I graduated from dental school, I actually had a rural dental practice in the Annapolis Valley for 10 years. And it was during those 10 years in my rural community, I did see a fair number of older adults in my practice, and really started to see some challenges facing the population as they were aging, particularly those who were entering long-term care and who I had an opportunity to see both through my practice, but through house calls that I would do for patients of mine when family would ask me to go. So it led to really a career for me that has been shaped very much by a focus on marginalized populations in general, but in particular older adults, and had run a elder care dental clinic here at the Faculty of Dentistry when I came in the early 2000s as a full-time faculty member. So for close to, I guess, 18 years, I oversaw an elder care practice with our dental students. So again, was really had a lot of opportunity to experience our aging population and what that means from a dental care perspective, because there have been a lot of changes in the last couple of decades. So I'm hoping that my talk this morning will kind of prepare us for the future, as well as help us understand the status quo a little bit. Before I leave this page, though, I just wanted to assure everybody that I wasn't making wine out of my grapes, but I was making grape jelly, and it turned out very well. So I'm starting with a little bit of a negative quote here, but I think it's important again to kind of situate things. So this Lillian Sutherland is a nurse who worked in rural Nova Scotia, and she had an op-ed piece in the Halifax Herald couple of summers ago, where she was looking after an older adult family. It was either a family member or a friend, I can't remember which. And her comment in the op-ed was, "Some folks have had little or no oral care for a very long time. Have a look in your loved one's mouth to see his or her state of care. Can you imagine not having your teeth cleaned for months or never?" And Lillian's also a nurse, and whose son's a dentist. So she was a little more maybe a little more aware of dental issues as a family and friend caregiver. But she did draw some attention to the issue. And I am happy to report that right around the same time, her her op-ed piece actually had there was the balance of it was that the government of Nova Scotia had just implemented some relevant policy in our long-term care sector, which I'll talk a little bit about in a few minutes. So this kind of concern or caution was also flanked with, you know, we know there are issues, and we know, we are really moving toward implementing some policy and practices to address these issues. So I guess this audience, if you're tuning into this webinar this morning, I have to assume that you have an interest in the area, and that you probably have a knowledge, as I do, about some of the things that we're facing in managing dental care and daily mouth care in general. And I also am going to expect that you know more than anyone that brushing and flossing are not mundane tasks when you're doing them for someone else. So I really want to emphasize that, having worked with the population and for many years, that I really see this as something that we have to adjust our thinking about the difficulty it is, and the resources and the experience that you need to do mouth care, daily mouth care well, and to do it in cooperation with patients who can sometimes be responsive, have responsive behaviors and so on. So just wanted to set that little bit of context. So today, really, I'm going to talk about kind of situating oral health a little bit, oral health, general health linkages, kind of a little bit of an oral health 101. And then to talk about some of the work we've done with health care providers and frontline staff workers with respect to what we can do about the challenges associated with mouth care in the long-term care sector. So situating oral health. Now I show this slide. This is a gentleman, Jason Jones in Ontario, a young man, I guess about a decade ago, who had a front page story in the Toronto Star done on him because of, just to draw attention to the difficulty that many members of the population have in accessing dental care. So that first picture of him shows him after he had most of his teeth removed, and it was his story about the discomfort he had over many months. He couldn't hold a job. He couldn't get a job, let alone hold a job. He was in a lot of pain, and he talked about actually chewing his food with his fingers before he would eat because of the pain he was experiencing. So that article brought a lot of attention to Jason, and he had a number of volunteers from the dental sector who offered to provide him with care with implants and dentures. And so a decade later, it shows him thriving with his young family, and that he's a steel worker and happy and healthy. And so I draw attention to this sort of extreme case because in long-term care, a lot of times our residents in care can't really communicate their discomfort and their experience, and their quality of life may be really being impacted. So I just wanted to draw our attention to that, and reminder that maybe some of the responsive behaviors that we have for people who have challenges with communication really may have something to do with kind of this chronic pain or discomfort, even halitosis, things that are impacting their quality of life, but maybe they can't express. So just to kind of go back to talk about status quo and maybe what we can expect to see in the future is around dental service utilization. So the Canadian Health Measures Survey, which is now, I guess, getting on to being about a decade old, it's the most recent one we have though, that 70% of Canadians had visited a dental professional in the previous year, with about 30% of avoiding going due to cost or avoiding treatment due to cost. So about 75% of people were able to access care. And 62% of Canadians do have private dental insurance, mostly within those who come from a higher income bracket. And 50% of respondents from the lower income bracket did not have any dental insurance. And the age group 60 to 80% do not have dental coverage. So this just talks a little bit about access to professional care and resources to support that care. So in general, about 50% of the population of the 60 to 80-year-old group don't have any dental coverage, and we really don't know what the rates are for people living in long-term care because the Canadian Health Measures Survey didn't have that data. But we can assume that at the highest level, about 50% would have access to funds to pay for professional care. So I'm just going to switch from thinking about utilization of how many people actually do have access through, I mean, put it this way, a lot of people living in community, about half do have coverage, and I would say that's probably a little bit of a high number just because of the way the survey was done, I guess. So my point is we don't know what's happening in long-term care as far as that goes. So just to switch back to our kind of Oral Health 101, I did want to just focus in on the two primary diseases that we deal with in oral health care. That is periodontal or gum disease and dental caries or dental cavities. And what a lot of people don't appreciate, I think, is that these two diseases are actually chronic diseases. We often don't think about that. I mean, we know diabetes is a chronic disease, and sometimes, lung diseases are chronic diseases, but we don't think about the fact that your dental health is actually primarily chronic disease. And so I think it situating it that way helps us to think about that it has to be managed over time. It's not an acute, we might have an acute toothache, but the actual disease process causing that toothache or causing that abscess tooth is actually a chronic disease and has similar risk factors to other chronic diseases, such as smoking and diet and social determinants. We'll talk a little bit about that later on as well. It can be controlled with prevention, though, and that is the good news. The other thing that's similar to other chronic diseases is that both periodontal disease and dental caries do affect general health. And so I spend a lot of my time, especially when I work in interdisciplinary teams and interdisciplinary research, that I spend a lot of my time talking about that, talking about the mouth and what's going on in the mouth actually does have a big impact on general health. So just to focus in a little bit on periodontal disease or gum disease and dental caries. And this is a picture of a gentleman probably in his early 80s. And what I'm showing you is, I guess, the sequelae or the results of these chronic diseases. He has a lot of dental fillings. I hope you can see my arrow here. A lot of amalgam fillings here. He has a large white filling here. So just, this is, evidence of someone who's had a lot of dental care over time. And also to show you here that he does have signs of periodontal disease or gum disease because he has a lot of receding gums here. So this gum line should actually be, if you can see my arrow, kind of at this level and has receded back to this level. So this is kind of what we see in the older adult population where there's been evidence of treatment for dental disease, and the fact that he's lost all of these teeth here is probably due to gum disease or periodontal disease. So I want to talk a little bit about plaque formation, because plaque formation is required for both of these diseases to take hold and to advance. So basically, there's kind of 4 stages through which, our saliva and the contents of our mouth, the liquid flow is transported to the mouth, and the bacteria that causes these diseases, periodontal disease and dental caries, actually has to adhere to a surface. So you need tissue or tooth structure, and it's primarily adheres to tooth structure. So it's transported into the mouth, it adheres to the tooth surface, and then it attaches over time. And this does take some time, but it's at this stage, at stages 2 and 3, that we can really have an opportunity to disrupt the adherence and attachment of dental plaque through brushing and flossing. And stage 4, colonization and biofilm formation, is where microcolonies of bacteria develop and the plaque matures. So plaque maturation, the more it matures, the more bacteria is associated with it, and the more it stays there, the more colonized the bacteria becomes, and the more virulent it becomes. And what I mean by that is the more damaging it becomes as it sits in plaque. So it's really important for us to be disrupting this every day with brushing and flossing to be that primary preventative mechanism. So I just want to also point out, as far as periodontal disease goes, it is a spectrum, okay? So we have a spectrum that goes from gingivitis, which is just a very sort of superficial inflammation on the gums, to advanced periodontal or gum disease. And so here I'm just showing, all of us have, go to the dentist, and we all would have our teeth probed to measure our periodontal health. And this is just a schematic of a periodontal probe to show you actually what dental hygienists and dentists are measuring. So a healthy situation, this probe would not be able to advance so far down the side of the tooth. So if in a healthy mouth, the probe would only be able to advance to about here, 2 or 3 millimeters. So this is just showing, I show this just so you can see that when the probe goes in further, that means you have a more advanced form of the disease where there's actually some bone loss and loss of support around the tooth. So just a reminder that there's this large spectrum. And this photograph, it just depicts the same spectrum in a somewhat different way. So here, this person has probably just had their teeth cleaned and flossed, but you really just here are seeing some evidence of early gingivitis, of a fairly mild gingivitis. As we go down the spectrum, you're seeing here there's calculus or tartar on these teeth, and now the gums are getting a little what we would call boggier or puffier. And if you touch those with a dental probe, you'd get a lot of bleeding. And you're just starting to see here a little bit of kind of the elongation of you're seeing the root of the tooth getting a little bit long in the tooth here. And then as things advance even further, you're seeing boggier tissue. And I suspect in long-term care, when plaque and calculus or tartar have had a chance to mature on teeth, we see a lot of this. And so we would touch this with a toothbrush or with floss, and we would get a lot of bleeding. Now, I always tell patients, and it sounds maybe a little strange to say this, but I would say don't worry about the bleeding. You need to gently brush these teeth. And in this case, they would need to have, the calculus removed with a professional cleaning. But if you're just cleaning plaque off, don't let the blood scare you, if I can say that, because it is a sign of gingivitis. And that if you're gently brushing over time, over a couple of weeks and flossing, that bleeding will actually diminish over time. You can actually reverse gingivitis to a healthy. Once it gets into sort of the calculus and periodontitis, you do need a bit more professional care to get things healthy again. But if you're on that prevention, you should be able to really, with brushing and flossing, keep that gingivitis to a minimum. So the other point about periodontal health, and we do hear a lot of this now in the mainstream media, is about how periodontal health and dental health really do affect your general health overall. So I just wanted to touch on that a little bit, because I really do think it's important for us, for those of us who are caring for older adults, particularly in long-term care. So we know and as a researcher, I know this because it's kind of what I deal with on a daily basis, is that in dentistry, we've had what we call a silo approach. So we've looked at dental health and dental health service really quite in isolation from other systems, other health systems. But in recent decades, there's actually been some links starting to be identified between oral health and systemic diseases. And even though causal links are yet to be, established with really high level of evidence, there are definitely some linkages that you're seeing between, the presence of periodontal disease and the presence of other more systemic diseases. And there have been some plausible mechanisms described to explain this. So why would poor oral health actually affect systemic health? And some of the reasons being that when you have kind of this chronic inflammation in your mouth, there are actually metabolites that can actually circulate in the bloodstream that will potentially have an impact on general health. And I just want to go back to this slide for a second, because I wanted to mention this because I think it kind of puts it in perspective for us. If you actually took the gingiva, the length of the gingiva like this, and the 1 or 2 millimeters in mild gingivitis, or even a little bit more, and you actually spread that out on a piece of paper and measured it, the area that is inflamed is actually the equivalent to about 4 square inches. So here you have a chronic inflammation that, if you actually looked at it in an area, a square inch area, would be about 4 square inches. So I always ask people to imagine, what would that look like if it was on someone's arm or leg? So you have this mild wound, and we all know in long-term care how we attend to wound care. And so in coming back to this point about the systemic approaches, thinking about it in terms that you always have this kind of bleeding, these bleeding tissues that enable, biomarkers and having an inflammatory response going on all the time in a person's body. And so that these elevated metabolites of inflammation actually do have the opportunity to circulate from the mouth into the system, and can actually react elsewhere in the body. So one of the ones we hear about the most is in heart disease. And so there have been some linkages with carotid thickening and reduced arterial elasticity associated with advanced periodontal disease. And when periodontal disease, when treatments are adhered, when there are treatments for the periodontal disease, looking at the patients after the fact, it does show there has been impacts on heart health. That's very promising. That does have the potential to lower risk of stroke and myocardial infarction. So, for example, they've identified an improvement in elasticity of the arteries, and a diminishment in the serum biomarkers that would typically be associated with chronic inflammation. The other one we hear about a great deal is uncontrolled diabetes, and we do know that chronic periodontal disease can be disruptive to diabetes control, and that people with diabetes, have type 2 diabetes, are 3 times as likely to develop periodontal disease than are people who don't have diabetes. So what happens in this case is there's actually a reciprocal approach, or bidirectional we call it, where if you have periodontal disease, it can influence your ability for good glycemic control in trying to manage your sugars as a diabetic. And it also, conversely, if you have diabetes, you're actually at higher risk for gum disease. And that's because we all know that diabetes can affect the microvasculature, or the capillary level of, has poor circulation, in other words. So if there's poor circulation to the gingiva tissue, in the same way that there's poor circulation to the toes, it does put a person at higher risk for diabetes. And so to that end, periodontal disease is actually now considered one of the 6 signs of diabetes, and and as I mentioned, has this bidirectional relationship. Aspiration pneumonia is also closely associated with oral health, and it really is very connected to plaque load. It especially affects adults in long-term care, and the risk for aspiration pneumonia is greatest for those who are dependent on others for their mouth care. And it can, once plaque control is actually brought under control, it can actually improve people's ability to swallow and reduce respiratory aspiration pneumonia. So I think that's a spot where I'm going to turn it over to Kate.
Yes, and now we have our first poll question for you. It should be popping up on your screen right now. So what we're wondering is which condition do you think is associated with poor glycemic control? So if everyone wants to take a minute or two and select which option you think is the correct answer, and then we'll report back with the results for you in just a minute. Yeah, so is it xerostomia, dry mouth, dental cavities, periodontal disease, or aspiration pneumonia? All right, and we'll give you a few more seconds to pick your response there. Great, thanks everyone. So it looks like 86% of you said that periodontal disease is the right answer. 9% said dental cavities, and 6% said xerostomia or dry mouth. And the correct answer is?
Periodontal disease. Okay. So moving away from periodontal disease for a moment to talk about dental caries or dental cavities. So dental caries refers to the actual disease process, and it is a microbiological transmittable. I mean, these bacteria are transmittable, and a lot of people, I guess, probably wouldn't realize that. But you can actually, you see this picture of the mom feeding her baby. Actually, if she has bacteria in her mouth on her teeth, she can actually physically transmit that bacteria to the baby. And so once that baby has teeth, that adherence process that I talked about a little earlier can actually start to take place right away. And when we talk about cavities, you can see here we've got kind of holes in the teeth and black, dark halo and so forth. That's actually the end result of caries, dental caries. That is the cavitation that the bacteria causes from acid breakdown. So bacteria produces acid and causes these cavities to develop in the mouth. So I just want to step back for a second and talk about the major risk factors that contribute to dental cavities. So basically, you have to have three things happening at the same time. You have to have destructive microflora, which just means the right type of bacteria in your mouth. You have to have a certain susceptibility to the microflora, and we'll talk a little bit about what that is, and also dietary factors. So these three things are sort of all happening at the same time. Multifactorial, we call that. So when we think about destructive microflora, what I showed you in the slide with cavitations, that person has high levels of this destructive microflora in their mouth, and we see that most destructively in what we call early childhood caries. And actually now there's this new phenomenon, rampant elderly caries. So in other words, it seems to be the extremes of age is where we see sort of the worst cases of caries associated with this virulent and destructive microflora. We also have dietary factors. I'm just going to move. I'm just moving my screen for a little second here, because part of it was blocked out. Yeah, so what we think about in dietary factors, I mean, everybody knows that sugar causes tooth decay. So we take it a little bit beyond that when we think about risks, because we all have a certain amount of sugar in our diet and carbohydrate in our diet. But it's not just simple sugar. It's not just pop or candies that can be a dietary factor. Even more complex carbohydrates like starch, something you might even have in a soda cracker sitting on the tooth can actually break down and be a risk factor for dental caries. So we can't ignore those kinds of dietary factors as well. And so again, these dietary factors can be associated with young children and adolescents, older adults, just because of the dietary habits they might have, and food insecure communities as well. when we think about host susceptibility, what this means is how everybody's different, everybody has a different history. So for example, if you grew up in an area where there's water or fluoride in your water supply, you might actually have a little more protection for your teeth than someone who didn't grow up with fluoride, particularly at an early age, because fluoride actually does work to strengthen teeth. So host susceptibility, meaning that we have different susceptibility to dental caries. For the elderly, there are a couple of things that really impact their host susceptibility, and that is multiple medications. We know that multiple medications really do have an impact causing dry mouth or xerostomia, and it can actually so the dry mouth actually is a physical, it puts you at a physical disadvantage, because when you have dry mouth, you don't have that natural protection of saliva. And saliva has a lot of good stuff in it to protect us, to wash away bacteria and to wash away acid and so forth, and to buffer acid in your mouth that causes dental decay. And a radiation treatment, if it's in the head or neck region, can cause dry mouth as well. Time for another question.
All right, so next up for the poll question is, what we want to know is, which of the following are risk factors for dental cavities, except for, and so this is where you get to pick one of the options. So is it except for multiple medications, diet rich in starch, fluoridated drinking water, mothers with high rate of cavities, or poor oral hygiene? So if you want to think about it for a minute and select which option you think is the correct one, we'll share the results with you in just a couple of seconds. All right, and it looks like there is a clear front runner. So 91% of you said that the right answer is fluoridated drinking water. About 6% of you thought a diet rich in starch, and 3% of you thought that the answer was poor oral hygiene.
Okay.
And then going back to it, the correct answer is fluoridated drinking water.
Right. Okay, so I'm just going to touch on this again, caries across the ages. So in children, I mentioned that there's a certain sector of the population who would have early childhood caries, which is this very kind of advanced caries. And a lot of people don't realize this, but the prevalence rate of early childhood caries is actually 5 times greater than asthma. So it is actually more common than you would think. And that most often this type of treatment does require a general anesthetic. So it's the main reason for pediatric for early childhood caries. It's the most common day surgery in pediatric hospitals. So it's not an incidental finding. And as I mentioned, because this is a chronic disease, it means that this has to be managed for these children for their entire lives. And it does impact, about a fair number of young children, especially children who are in high risk populations. As we get into middle age, so in middle age, this is just a picture to show you this kind of high rates of dental treatment historically, that 96% of adults would have some history of dental decay. And when we get into older populations, baby boomers and seniors, we see more missing teeth, higher rates of edentulism, which means no teeth, higher rates of periodontal disease, and so forth. And baby boomers actually have slightly lower rates of missing teeth and periodontal diseases, but they're more likely to report oral health problems or perceive their oral health as poor when compared to seniors. And this is done through survey work. And the reason I bring this up is, some baby boomers are now seniors. And so what we're going to expect to see in the next generation is people who are a lot more aware of their dental health, a lot more aware of their oral health and problems, so that we might sort of see a more attention drawn to oral health as the baby boomer populations age into seniors. I'm just going to skip this slide because I realize that the time is marching on, and I want to get to some of the other points that I want to make. So another kind of couple of quotes that are a bit that are a bit jarring for those of us who are in the business. That, you know, one of the directors of nursing that we worked with in one of our research projects said, at this point, I think I want an advance directive to ensure all my teeth come out before I enter a nursing home. At least I know dentures may be easier to get out of my mouth to be cleaned. And so again, I'm sure all of us can appreciate where that might be coming from. You know, she's probably concerned with the difficulty in care, you know, in getting the care and providing the care, having worked in long-term care. And she's probably also concerned about the consequences of if she didn't get care or didn't have access to care, and the discomfort associated with that. So it, you know, it just kind of brings home you know, it is a challenge even for those of us who are working hard to advance oral health. The other quote is, you know, the epidemic of poor dental hygiene, and again, it just kind of brings home the difficulty of providing care. And speaking as a dentist, you know, I often think about people, and families will often come to the dentist before their family member is entering long-term care and say, you know, I think they need their dentures before they go into long-term care. And really at this stage of the game, it's impossible to make dentures. So now we're kind of in the sticky wicket of, you know, not being able to provide dentures in someone, especially if they have early dementia. Really difficult to make dentures. And I always say, you know, imagine, you know, how hard it is even to get used to a new pair of shoes, and you're thinking about getting used to this thing in your mouth that's hard plastic. And so to do it at kind of a late stage in age is much more challenging. But to respond to the quote about the lack of daily care in nursing facilities being problematic, you know, I put up here, I mentioned earlier about Nova Scotia bringing in some good guidelines around daily care and assessments of oral health. And I know Ontario follows a similar model in terms of, you know, your regulations being quite patient-centered and person-centered, and, you know, as we say, mindful of the fact that people in long-term care, you know, this is their home, and they the care that goes with that, you know, has to be conducive to their daily living in a home setting. They're not in an acute care setting, so that the way care planning has to be set up, or care planning should be set up, is conducive to that kind of person-centered care. So this just highlights in Nova Scotia some of the requirements that are in that. And again, very similar to Ontario, you know, that people have assessments, they have a daily mouth care planning that's part of their planning overall. So I point this out because what we've seen, you know, maybe a generation, or, you know, one generation ago, and we're seeing less and less of, is someone with complete dentures. And now we're really seeing much more of people with a full complement of teeth, and people with evidence of decay, and lots, you know, this is someone with lots of plaque, someone who's been in who's actually been quite well cared for in long-term care, but just seeing the results of knowing how difficult it is to provide that care. And then we also have Mrs. B, who is one of my patients here that I looked after for close to 20 years, who over that 20 years never had a cavity, was able to look after her teeth really well. So just that broad spectrum. And this is I show this case because it demonstrates, this was a patient we saw who in the dental faculty who had a full complement of teeth. He had a stroke, spent 18 months in acute care and rehab care, and the day before he left care to be discharged home from rehab, he had 14 of his teeth removed. So it showed that in that 18 months where his mouth care had not been attended to in any way, that his teeth just really, there was just a huge downslide in his oral health. And he actually functioned quite comfortably for many years with just these few teeth. And but there was no way we could have made dentures for him at this point. So again, this is just someone who's kind of falls in between that, you know, those very extremes of spectrum. So we talked a little bit about some of the general health linkages, and I did want to just point out again that improvement in oral hygiene actually does decrease risk of dying. It's that extreme, and that decreased respiratory pathogens associated with high plaque loads can actually improve swallowing and the cough reflex. So, you know, there really is a lot to be concerned about when plaque isn't removed on a daily basis. And so finally, I do just want to, you know, talk a little bit about, well, you know, we know it's a challenge to provide care, but what can we do about it? What are some things that we can do about it? And I mentioned about fluoride in drinking water. Fluoride is one of the few things that we can offer that's sort of a medicament, if you will, that will reduce demineralization associated with dental decay. It promotes remineralization, and it actually has a bactericidal effect. It actually can kill off bacteria. So the more ways that we can safely provide fluoride, the better. And there's even, you know, some research that shows daily use of a highly concentrated fluoride toothpaste or mouth rinse really does have an impact on decreasing dental decay. And sometimes, and I know in my practice when I used to go to long-term care, just about every patient had a prescription for daily fluoride rinse if they were able to spit, you know, to be able to expectorate properly. And the other thing I did a lot was fluoride varnish, providing fluoride varnish at 3 to 6 months intervals. And sometimes in my private practice, I would even be doing fluoride varnish at 1 month intervals. And that is, you know, was because it's one of the few things we can do when there's high rates of dental decay. So I guess I'm bringing this up because if you're working in a long-term care sector and you have dental hygienists coming in, dentists coming in to provide care, you may be seeing more more doctor's orders or you know, requests for fluoride, because as people keep their teeth, I think we're going to see the need for a better understanding of fluoride or better application of fluoride going up. And then xerostomia, we mentioned that common side effects of more than 500 medications that reduce saliva flow. And so that reduction of saliva can really impact quality of life, reduce efficiency of chewing, and so forth. So something we have to be attentive to and maybe respond to in how we provide care. You know, sips of water, ice chips, rinsing the mouth, you know, when there's swallowing difficulties, using moist cloth to moisten the tissues to really improve or to offset that xerostomia. And the other thing we need to think about is avoiding products that irritate mouth tissues. So petroleum-based products such as Vaseline, lemon or glycerin swabs, mouth rinse with alcohol, hard bristle toothbrushes should all be avoided in order to diminish the possible irritation to mouth tissues. Oh, I guess it's time for another question, Kate.
Yes, it is. All right, so this question that we have up on the screen now, so we want to know what your preferred response is to the statement. The presence of fluoride protects teeth from bacteria by resisting bacterial attack, reducing demineralization, promoting remineralization, or all of the above. So if you want to take a couple of seconds, think of what you think is your preferred or the correct response, and then we'll show you what the results are. All right, and it looks like everybody who voted thinks that the answer is all of the above, and the correct answer is?
Oh, all of the above.
All right.
Very good. Good. So yes, I guess one of my colleagues, a dental hygienist, I loved her comment. She says, "Fluoride is my favorite F word." So that's a good reminder. Okay, so another question.
Yep. So, and then this next poll question is: we want to know which of the following is not recommended as a palliative approach to mouth care. So, is it saline, lemon or glycerin swabs, soda water, non-alcohol fluoride rinse, or a moist disposable cloth? And we'll give everybody a few more seconds to think about it and select which answer you think is the correct one, and we'll show you the results. All right, thanks for voting, everyone. So 86% of you think that the answer is lemon or glycerin swabs. 11% of you are thinking soda water, and 3 of you think the answer is saline. And then going back to the webinar slides, the correct answer is lemon or glycerin swabs.
So 86% were correct on that one. Okay, so I'm going to just move now to the Brushing Up on Mouth Care program, and this is a kind of a result of a research project that's had taken place in Nova Scotia some years ago. And just to sort of, I'm going to shamelessly promote Brushing Up on Mouth Care, but because it's open access. We have an open access website, so any of the materials that I'm going to show you in the next few slides are available for download for free for education purposes. So we do have kind of a copyright, but the copyright is very liberal, meaning that you can use any of our materials, and we hope you will use our materials. And the Brushing Up on Mouth Care, so I've shown you here the our domain name, which is brushingup.ca, and we're actually in the process right now of relaunching our website under this new domain name. So within a month or so, you'll be able to get access to everything through that domain name. It is still available now, but it's a little bit more complicated to find it. So I just wanted to point that out as we get through. What this research, where this program came from, or these resources came from, is a research project that we did that we called it a community-based research project. And what we mean by that is we went into long-term care and we worked directly with frontline care workers, continuing care assistants, personal support workers, anyone on the front line, nurses, nurse managers on the front line to develop these products. So the credibility of the products come from the fact that they were developed from the ground up, meaning that we didn't do anything without the care staff, either telling us this is what they need, or B, without vetting everything through care staff before we developed it and put it on our website. So this just gives you kind of a little collage, but I'll go through some of the products. So one of the first things we developed was a toolkit, and we all know how important toolkits are. We need to have to be able to have quick access to resources, and we actually had about 6 or 7 prototypes that we went to the 3 long-term care facilities that we were working with to have the staff help us come up with a design. And this is what we came up with. And it seems very simple, but it's very practical. It has a beer cup that you can buy at a dollar store that they could write the person's name on, that was disposable. One of the big problems with long-term care and having these kinds of kits was sterilization of, if you had, depending on if you had an emesis bowl or something that you're keeping things in for storage. And so this enables you, in some facilities, depending on the standards, they were allowed to actually attach these to the wall in the washrooms if they had private washrooms, and in other cases they would put them in a cupboard. And either way, this little wire basket is amenable. And so this is, we've actually installed these in many rooms throughout Nova Scotia. We also developed care cards, and we actually laminate these with, they're laminated so that they can actually be tucked in the back of the toolkit. We would actually have them customized for a person, whether they had natural teeth or natural teeth plus a partial denture or no natural teeth. And all of the instructions on them are basically customized for that situation. And then the laminated card enables you to write extra notes. Mrs. Jones prefers to have her teeth done after breakfast, or mid-morning, she likes to sleep in, and so the care staff would use these to customize and then communicate with each other from person to person and shift to shift. We also developed all of these information sheets. Again, the care staff told us what they wanted to know more about. So we had our research staff, dental hygienists, and our research coordinator who researched all of these topics and came up with these information sheets, and actually we've just had all of these reviewed and validated as we're developing our new website. So everything should be pretty up to date with current research. We also developed some information about toothbrushes, like various products and aids, mouth rinses, denture products, and so on. So again, all of these topics are available free on our website. And lastly, or not lastly, one more thing that was really a critical piece is education videos. So we have these videos that are actually all streamed online. You can just download anything. You can actually look at a table of contents and pick out pieces that you're interested in. And the topics are oral health, the basics, some of the stuff we talked about today, brushing technique, how do you actually do it, considerations for dementia, palliative care, oral health assessment, and so on. And I just want to highlight the considerations for dementia one, because it's probably the one we spent the most time on, and we're actually very fortunate to have the help of the specialist team in Nova Scotia on responsive behaviors. So these are consultants that go throughout the province to assist people working in residential care with patients who have difficulty or have responsive or sort of challenging behaviors. So we've got a lot of feedback and input. So this video I've probably gotten the most feedback on about its practicality and straightforward approach to trying to manage daily mouth care for people with dementia. We also have assessment forms, and on our video on assessment, oral health assessment, it goes through how to do each of these topics. And with that is a care planning tool as well. And I just point this one out. And this is, again, it's probably, I'm not sure how clearly you can see it on your screens, but it's actually a bit of a flow chart and guiding principles. And this was established, again, with the teams in long-term care about what's the best path of care for doing an assessment and finding a resident who may or may not have concerns, and also providing guiding principles about what every resident can expect, in terms of assessment, oral planning, daily care. And then they also committed to each person having a care card and toolkit in the room. So these were guiding principles that came out of the facilities that we worked with, and that have actually expanded to many others in Nova Scotia. And this facilitator guide is actually another great resource that we developed with a nurse educator. And what we did was we got the nurse educator to help us with how to take what we've learned and all of the information and resources we've had and put it in a package that would be most beneficial for nurse educators using this. And so this is a very detailed guide. I think it's about, if you downloaded it as a PDF, it would be a couple of hundred pages, but it actually goes into great detail, and it gives even citations on our videos of where you can find more information about a certain topic and so on. So it really walks a nurse educator through taking all of these resources and being able to run their own nurse education program in long-term care. So a way to sort of train the trainer, and a way to really get that information to where it needs to go, in the way that nurses and care staff are most accustomed to having their education presented. Oh, got time for another question here.
Yes, so we have a quick question for everyone. So we want to know, it's a quick test, what do you think the new domain name is of the Open Access Brushing Up on Mouth Care website? And so if you want to put in your response in the questions box on the right-hand side of your screen, that would be fantastic. You might have to click on the arrow beside where it says questions to get the box to expand. Yeah, and so the question again is, what do you think the new domain name is of the Open Access Brushing Up on Mouth Care website?
There it is.
Yep, we're getting responses in. Looks like people got it right. Brushingup.ca. Thank you.
As I said, I'm risking shameless promotion, but I really, these materials, as I said, the credibility comes from where they come from, from from residential care. And we just had a class of dental hygiene students actually review all of the materials as part of their coursework to ensure that all of our materials are up to date. So it's just such opportunity, and as soon as we get our new domain name up, you'll be able to access it through brushingup.ca. Right now, if you just Google Brushing Up on Mouth Care at Dalhousie University, it will take us to our current site, but the newer site will be a little more accessible. So I think I'm probably cutting it close with not a whole lot of time for questions, but I really want to thank you for your attention. It's a little bit unusual to do a webinar where you don't have faces in front of you to respond to, but I really have enjoyed presenting this, and I'm really happy to take any questions if Kate wants to coordinate that.
Yeah, thanks very much, Mary. And we have the question on the slide and out there to you all. So if you have any questions or comments for Dr. Mary McNally, if you could again, please put them in the questions box on the right-hand side of your screen there. And it looks like there's a couple questions already. So Linda was wondering if you make entries into the resident assessment instrument for oral and dental, have you gone back to see if your processes are being followed?
Yeah, we have to a point gone back to our processes being followed. Of course, with research, what happens is the research project always has a finite ending. But what was really encouraging for me is I did a similar presentation to this last fall to a broad spectrum of care staff in long-term care. And where I know that our products are being used, or where we're having program uptake, is when the policy was implemented in 2016, a number of people in the audience told us that they were being cited for not being compliant with the assessment and care planning part of the new policy, and that our materials were actually what the government assessors were actually providing them to use for helping them to become compliant with the policy. So it was really encouraging. We have gone into some long-term care facilities and we've actually helped them set things up with the toolkits and so on. But because I'm kind of the solo person now, it's hard for me to do that every time that I'm asked. But certainly when we've been able to team up, we've been able to see, and certainly there are many long-term care facilities in Nova Scotia using the program.
All right, thanks, Mary. And we have a couple more questions for you here. So someone else is wondering, what would you suggest to use instead of toothpaste for elderly patients who cannot expectorate?
Instead of toothpaste. Well, I guess if they can't expectorate, then you can't really just substitute it with something else. If you had a little low volume suction, which I know is probably not available, I really don't, except for whether you could actually use a tiny bit of toothpaste and just literally use a 2x2 on your finger and just wipe it away, because it doesn't hurt to leave a little bit of toothpaste on the tooth surface, actually, because it actually lets fluoride still sit on the teeth. You just wouldn't want to provide any amount of volume in their mouth with fluoride and water if you weren't allowed to remove, if you weren't able to remove it, or if they weren't able to expectorate. So I would just suggest, same as we do with young children, we talk about the size of a grain of rice, putting on the toothpaste and then just really kind of foaming it up a little bit as best you can with brushing. And then that tiny bit of amount, like same as in a young child who maybe doesn't know how to respond to the command to swallow or to spit, actually it's not a health risk to use that tiny amount of fluoridated toothpaste. I hope that helps.
Yeah, thanks, Mary. And there was somebody else who commented that there's a product called Paravex that is a no rinse product.
Well, yeah, I guess, yeah, and it's probably very, as I say, I mean, toothpaste used in a small amount could be a no rinse product as well, right? You'd want to use probably a gel in that case. But yes, the Paradex product is is another one that can be left on.
Okay, great. And we have another question here. Somebody else wants to know or says that removing and replacing partials can be the most difficult for people living with dementia. Are there tactics for this in your video?
The video actually focuses more on actually brushing, but you could definitely use the same approaches in trying to remove dentures, because a lot of what the video talks about is really how to get the resident more comfortable and approaching them in sort of the least challenging way. So I would think, I can't recall if there's anything specific to dentures, but I would suspect that you would be able to use some of the same techniques in terms of getting partials out. And I do sympathize. I know how difficult it is. Sometimes it's difficult getting a partial out from someone who doesn't have dementia and who's actually able to help you. So I do appreciate that can be quite challenging.
All right, thanks. And we'll take care of these last two questions here. So one is a statement and a question, which says medications are commonly crushed and mixed with applesauce or jam for residents with dysphagia. What would you recommend in place of those, such as low or no sugar products?
Yeah. Actually, I meant to actually mention that. And a lot of times, some medications are even put in syrup and actually given, after mealtime. Applesauce, I mean, really, as long as if it was part of a meal, then the patient's going to have it, the resident's going to have it anyway. So you would just handle things in the normal way. And there may be some other products if the resident was amenable, would be like yogurt, because we know that lactose actually has a bit of an anti-cavity effect. So if yogurt might be another option, or just straight up products that have no sugar in them, that are just you can get jellos that have no sugar and so forth. But yogurt would probably be a good option, I would think.
All right, thanks, Mary. And then somebody else is saying, I read somewhere that toothpaste affects thyroid function. Is that true?
That would be a new one on me. I've never heard that. Never heard that.
Okay.
So yeah, there may be some research to be done on that, but it's nothing that I'm familiar with. Okay.
And last but not least for questions is, does Nova Scotia use the RI or the Resident Assessment Index in long-term care?
I don't think it's uniform across the province. I think some long-term care facilities do use it as part of their accreditation. So not all long-term care facilities have national accreditation. So I would say that it's not consistent across the province, but I do know that some are using it, some of the larger ones in particular.
All right, and somebody else just stated it's not the toothpaste, but the fluoride in the toothpaste that is said to affect the thyroid.
Yeah, again, that would be research I'm not familiar with.
All right, and we'll just wrap things up here. So thanks again, everyone, for joining us for this webinar. We would really like to know your feedback on it and any suggestions you have for future webinars, including webinar topics and presenters. So a short online survey link is going to be emailed to you soon. Thanks again to Dr. Mary McNally for sharing with us this informative and useful information and all of the practical brushing up on mouth care resources. And special thanks to Holly Hebner from the RA for her fantastic webinar support. We're going to be ending the webinar now, but please contact us anytime with questions. We will be sure to send everybody who registered for this webinar a email notice letting you know when the brushingup.ca website goes live. So thanks again, everyone, and I hope you enjoy the rest of your day.
Thank you.